The group of drugs is antiviral agents. Okay, we have already looked at two classification of drugs, so we have to proceed and look at antiviral agents. So an antiviral drug or an antiviral agents are drug class of medication that are used specifically for treating viral infection. So working against viral, that is viruses. So antiviral drugs are a class of medication used specifically for treating viral infections. Like antibiotics for bacteria, specific antiviral are used for specific viruses. Like on the types of bacteria that we have got different types of bacteria and antibiotics working against those that can be gram negative, gram positive, and the likes. So even for antiviral drugs, we have different specific drugs for each and every species of virus. And like most antibiotics, antiviral drugs do not destroy their target pathogen. Instead, they inhibit their development. So for most antiviral drug is to inhibit the development of the virus or the multiplication of the virus. Whilst when you are talking about antibiotic, we are talking about the issues of bacteriostatic, okay, and bactericidal. So in antiviral agents, they are going to interfere with the viral multiplication. So antiviral agents are used to inhibit the production of viruses that causes a disease. Most antiviral agents are only effective while the virus is replicating. It is difficult to find medicines that are selective for the virus, as viruses share most of the metabolic process of the host cell. However, some enzymes are only present in viruses, and these are potential targets for antiviral drugs. Okay, so because the virus tends to use the multiplication system of the cell. Okay, so these viruses tend to have specific enzymes that can be targeted. Okay, in pharmacology to try to fight that viral infection. So that's why we are saying it is difficult to find medicines that are selective for the virus. Okay, but they share because they share most of the metabolic process of the host cell. But we just look at the enzymes that are produced or that are needed for that multiplication of that particular virus. Okay, and that will be targeted when coming up with antiviral agents. So agents that might inhibit the transcription of the viral genome are DNA polymerase inhibitors and reverse transcriptase inhibitors. So protease inhibitor inhibit post-translational events. Other antiviral agents inhibit the virus from attaching to or penetrating the host cell. Immunomodulators induce a production of host cell enzymes, which stop viral reproduction. Integrase strand transfer inhibitor prevent integration of viral DNA into the host DNA by inhibiting the viral enzyme integrase. So these antiviral drugs here, and then we have neuraminidase inhibitor that block viral enzymes and inhibit production of viruses. So with this said, we have to specifically look at these enzymes, especially for the HIV virus, okay, and the enzyme that the enzymes that get blocked. Okay, so we'll now look at the viral life cycle. We'll look at the viral life cycle so that okay. So now, giving a preview. Okay, what we're saying is just giving a preview of some enzymes. Okay, these are examples of some enzymes that get blocked when someone takes an antiviral. So when you talk of protease inhibitor, they are going to inhibit the protease enzyme. Okay, so they inhibit the protease enzyme. So we have drugs that are known as protease inhibitor. Okay, so they inhibit the post-translational events. So other antiviral agents, they may inhibit the virus from attaching to or penetrating the host cell. So we have what we call fusion inhibitors. Okay, so those that prevent the fusion. Then we have immunomodulators that induce a production of host cell enzymes which stop viral reproduction. Then we also have integrase strand transfer inhibitors. These prevent the integration of the viral DNA into the host DNA by inhibiting the viral enzyme integrase. Okay, then we have the neuraminidase inhibitors. These they block viral enzymes and inhibit reproduction of the virus or the viruses. So now let's talk about the virus cycle. Okay, so the virus consists of a genome and sometimes a few enzymes are stored in a capsule made of protein. Okay, so that capsule is known as a capsid and sometimes covered with a lipid layer, sometimes called an envelope. So viruses cannot reproduce on their own and instead propagate by subjugating a host cell to produce copies of them, thus producing the next generation. Viral life cycles vary in their precise details depending on the species of the virus, but they share a general pattern. Attachment, they share they share a general pattern. So there will be attachment to a host cell, so the virus as they come. So this is the pattern that they share. So the virus will enter the body, the blood system, and the lights. So it will then attach to a host cell. Then there will be release of viral genes and possible enzymes into the host cell. Okay, then after that, then there will be replication of the viral component using the host cell machinery. Then there will be assembly of viral components into complete viral particles. Then there will be the release of viral particles to infect a new host cell. So these are the stages or the general stages for viral replication, where there is attachment. Okay, then the release during fusion, there is release of viral genes and the possible enzyme into the host cell. So the virus empties its content into the host cell. When it empties its content into the host cell, then there will be replication of viral components within the host cell machinery. Then there will be assembly of viral components into the complete viral, that is the assembly of viral components into complete viral particles. So when there is this assembly, then the virus can leave that cell and attain an envelope, okay, and mature to go and infect other cells. So there'll be release of viral particles to infect new cells. So these steps should be looked at as the general steps on how the virus infects, okay, a host cell, how it will multiply within the host cell, and then what happens afterwards when the virus has to affect other cells. Okay, so to explain this one, the example here where we have the infecting virus here, and here I'm looking at the HIV life cycle. Okay, so we have the infecting virus. Okay, so this is the infecting virus here. So when the infecting virus finds the suitable host cell, it will attach to the host cell. Okay, after it attaches to the host cell, then this it is going to fuse with the host cell by releasing its content within the cell. Okay, so when it releases its content within the host cell, we have the reverse transcriptase. Okay, that is it trying to combine, okay, the HIV RNA into the human that is it into the human DNA. So they are now here we have HIV transcriptase here, okay, that is, and then we have the HIV DNA, okay, that is it. The HIV RNA has been combined to the human DNA. So this is with the assistance of the enzyme reverse transcriptase. Okay, so now we have a new HIV, also we have a new host DNA with the HIV genetic information. Okay, so when this happens within the cell, we have the integrase enzyme. So this new HIV with a DNA, with this new host DNA with HIV component, it is going to be integrated within the host cell. Okay, it's going to be inserted within the host cell. So here, this part here shows that this new part of the DNA has been inserted to the host DNA. Okay, so when it has been inserted within the host DNA, we are going to have the messenger RNA that has the HIV information. Okay, so this messenger RNA that is coming from the host DNA, it has the information to produce proteins that are needed by the virus. So there will be insertion in the host of the genome. So this messenger RNA now it comes out here. You have seen that it is coming out. Okay, so when it has come out here, then we are going to have the assembly of all particles that are needed by the virus. Okay, when the particles that are needed by the virus have assembled, okay, then they will come out or they will bud out of the cell, okay, as a new virus. Okay, so when they bud out of the cell as a new virus, of course, we have the protease enzyme that helps to cut those long HIV strains, okay, into smaller ones that can be used by the virus. Okay, so HIV precursor proteins there and the protease there. So this, then we have the assembly of RNA here at the bottom. We have the assembly HIV precursor proteins here, and then they are now released. As they are released from the host cell, they are released and they create some pores, okay, or some defects on the cell, destroying the CD4 cells, which are the host cell for the HIV, okay? But as they come out, they acquire an envelope, okay? They acquire an envelope and it's a full virus. So we have the virus here attaching and fusing, and then we have the virus out here budding out of the cell. Okay, so when coming up with antiviral drugs, we try to target these enzymes like reverse transcriptase, integrase, okay, protease, we target this, okay, and also here fusion, we can also have those that are specific to prevent fusion. Okay, so now um, and viral agents. So the dynamics of the HIV infection, the life cycle of HIV from infection of an target cell to production of new virions is about 1 to 2 days. Okay, so that is to 1.2 days. The time that the virus exists as a virion in plasma outside of the target cell is about 10 to 20 minutes. Each infected lymphocyte produces about 4,000 new viral particles. About 99% of the total body viral burden exists in the peripheral lymphocyte population. And then about 1% of the total body viral burden exists in long-term sanctuary sites, for example, monocytes, macrophages, and dendritic cells. So before cell entry, one antiviral strategy is to interfere with the ability of a virus to infiltrate a target cell. The virus must go through a sequence of steps to do this, beginning with binding to a specific receptor molecule on the surface of the host cell and ending with the virus uncoating inside the cell and releasing its content. Viruses that have a lipid envelope must also fuse their envelope with the target cell or with the vesicle that transports them into the cell before they can uncoat. Okay, so this stage of viral replication can be inhibited in two ways. Okay, using agents which mimic the virus associated proteins, okay, and binding to the cellular receptors. This may include virus associated proteins, antidiotypic antibodies or natural ligands of the receptor and anti-receptor antibodies. Okay, so here we have some drugs that they try to go on those receptors so that when the viral proteins tries to go there, they find that that receptor is already occupied. So the virus, by doing that, so the virus will fail to multiply. Using agents which also mimic the cellular receptor and bind to the same receptors there. That is the viral. That is the viral associated proteins. Okay, so when the you can use agents which may mimic the cellular receptor and they bind to the viral associated proteins. So this includes antiviral-associated protein antibodies, receptor uh, anti-idiotypic antibodies, or extraneous receptor and the synthetic receptor mimics. Okay, then we also have what we call entry inhibitors. So a very early, a very early stage of viral infection is viral entry. Okay, that is when the virus attaches to and enters the host cell. A number of entry inhibiting or entry blocking drugs are being developed to fight HIV. Okay, so HIV most heavily targets the immune system's white blood cells, known as helper T cells, and identifies these target cells through T cell surface receptor, which are designated as CD4 and CCR4. That is CCR5, okay? Then attempts to interfere with the binding of HIV with CD4 receptors have failed to stop HIV from infecting helper T cells. But research continues on trying to interfere with the binding of HIV to the CCR5 receptor in hopes that it will be more effective. Okay, then uncoating inhibitor. We have preconazole, which works against the rhinoviruses, which cause the common cold. Okay, rhinovirus causes common colds. So by blocking a pocket on the surface of the virus, that controls the uncoating process. This pocket is similar in most strains of rhinoviruses and enteroviruses, which can cause diarrhea, meningitis, conjunctivitis, and encephalitis. Okay, so here I have a group of some drugs here, okay, and the enzymes that they block, so the drug class and then their mode of action. So this can help in distinguishing between mode of action of the nucleotide reverse transcriptase inhibitors and the non-nucleoside reverse transcriptase inhibitor that are used in HIV. Okay, so there is a nucleoside drug. So we have what we call nucleoside reverse transcriptase inhibitors, okay, as a drug class. The mode of action of a nucleoside reverse transcriptase inhibitors is contain 40 versions of the building blocks, that is the nucleotides, that are used by the reverse transcriptase to convert RNA to DNA. When these transcriptase uses these 40 building blocks, the new DNA cannot be built correctly. Okay, that is a nucleoside reverse transcriptase inhibitor. Okay, so we have these drug, okay, that contain 40 version, okay, of the building block. So when the virus recognizes these as the protein that it needs, okay, it makes it difficult for the virus to build itself. Hence, the virus gets damaged or it fails to produce itself when you use nucleoside reverse transcriptase inhibitor. Then when you use non-nucleoside reverse transcriptase inhibitor, um, this inhibits viral DNA synthesis by attracting itself directly or binding to reverse transcriptase enzyme and thereby preventing it from converting RNA to DNA. Okay, so when you talk of non-nucleosides, these are false pseudo building blocks okay, that attaches directly to the reverse transcriptase, hence preventing the translation of HIV RNA into the host DNA. So that is what necessarily it does. When you talk of nucleoside reverse transcriptase inhibitor, they are on top. They are contain 40 building blocks of nucleotides that if the virus uses, then the virus fails to build itself. Okay, so now during viral synthesis, a second approach is to target the process that synthesizes virus components after a virus invades a cell. So reverse transcription. One way of doing this is to develop nucleotides or nucleosides analogs that look like the building blocks of RNA or DNA, but deactivate the enzyme that synthesizes the RNA or DNA once the analog is incorporated. This approach is more commonly associated with inhibition of reverse transcriptase. Okay, inhibition of reverse transcriptase, which is an enzyme there, which the HIV virus uses. So, preventing conversion of RNA to HIV RNA to the host DNA. Then, with the normal transcriptase DNA to RNA. Okay, then the other target is the enzyme integrase. So, this one is involved in splicing the synthesized DNA into the host cell genome. Okay, then transcription. Once a virus genome becomes operational in a host cell, it then generates a messenger RNA molecules that direct the synthesis of viral protein. So when you give an integrase inhibitor, it is simply going to prevent the sending of information, okay, to produce more of viral protein. So the production of messenger RNA is initiated by proteins known as transcription factors. Several antivirals are now being designed to block attachment of transcription factors to viral DNA. So integrase inhibitor is preventing these transcription factors so that the virus will not have proper proteins for it to assemble and build itself. Okay. So three drug classes currently available includes nucleoside reverse transcriptase inhibitor, okay, competitively, which inhibits the enzyme that facilitates the conversion of HIV RNA to HIV DNA. Okay, so because the HIV virus itself is RNA by nature, for it to find a way of joining into the host DNA, it has to be converted to RNA using the enzyme reverse transcriptase. So a reverse transcriptase inhibitor is going to prevent this conversion of HIV RNA to HIV DNA. Okay, so it's the HIV DNA that now attaches to the host cell. Then we have the non-nucleoside reverse transcriptase inhibitor, which directly binds to and thereby inhibit the enzyme that facilitates the conversion of HIV RNA into HIV DNA. Then the protease inhibitor, they prevent the virus from making new copies of itself by blocking the protease enzyme that cuts up the proteins needed for new copies of HIV virus. So some viruses include an enzyme known as a protease, okay, that cuts viral protein in parts so they can be assembled into their final configuration. HIV includes a protease, and so considerable research has been performed to find protease inhibitors to attack HIV at that phase of life cycle. Protease inhibitor became available in the 1990s and have proven effective, though they can have unusual side effects, for example, causing fat to build up in unusual places. It may also bring about improved protease inhibitor. It may also bring about improved protease inhibition that is for someone who is infected. And protease inhibitors have also been seen in nature. A protease inhibitor was isolated from the shiitake mushroom, okay, Lentinus edodes, that is edodes, okay. Then the presence of this may explain the shiitake mushroom noted antiviral activity in vitro. Okay, then the release phase. Okay, on the release phase, the final stage in the life cycle of a virus is the release of completed virus from the host cell. And this step has also been targeted by antiviral drug developers. Two drugs are named zanamivir or Lelenza and oseltamivir, that is Tamiflu, that have been recently introduced to treat influenza, prevent the release of viral particles by blocking a molecule named neuraminidase, okay, that is found on the surface of flu viruses and also seems to be constant across a wide range of flu strains. Okay, so here we have the class of drugs. Okay, we have the NRTIs, that is the nucleosides and nucleosides reverse transcriptase inhibitors, and then we have non-nucleoside reverse transcriptase inhibitors, that is NNRTIs, and then we have protease inhibitor. So shown below also are some examples under NRTIs, that is dovidine, lamivudine, stavudine, didanosine, okay, and the likes. Okay, then when you notice most of the drugs on NRTIs, they end with INE, okay, except abacavir, okay, abacavir and tenofovir. So those they have got a different way in which they end, okay, but that is to do with NRTIs. Most of them end with INE. Then we have NNRTIs. So on NNRTIs, we have nevirapine, efavirenz, and we have lipirivine. Okay, so we have a few drugs actually on the NRTIs. Okay, so you can remember them by EN, that is efavirenz and nevirapine. Okay, there's so those are some of the drugs there that can be used. And then when you talk of so mostly the drugs that are found under NNRTIs, they have very in between or at the middle, they are very, like from virus, they are very in between. So you can remember, always remember them in that way. Okay, then the PIs at the end there, most of them they are very at the end of okay, they have the very at the end of the same drug. We find that there is VIR. So we have returnevir, indinevir, saquinevir, neofinevir. So they are in, most of them end with the ver. Okay, so those are some of the drugs. There are classes available in Zambia. Of course, some new drugs have come in, like dolutegravir, which is an integrase inhibitor. Okay, so those are some of the new drugs that have come in. Okay, so when you're talking about the combination of drugs, mostly it is two drugs from NRTIs, you give two, and then from two NRTIs, you give one. Okay, and then mostly that's how drugs are given. So it's one from NNRTIs and two from NRTIs. Okay, so it also now depends on the schedule for them to add the PIs. Okay, so it's also important to know the generic name of the drugs, the acronym, okay, and also the trade name of these drugs. So when you talk of zidovudine, they find that they are abbreviated as ZDV or AZD. Then the trade name is Retrove. Okay, lamivudine abbreviated as 3TC. Okay, stavudine as D4T. Okay, so we need to know also these acronyms for these drugs because in practice mostly they just use these acronyms, mostly the issue of avoiding stigma, so you just mention them like this. Okay, nevirapine there, the acronym NVP. Okay, so With now that discussed, let us look at management of patients on antiretroviral drugs. How can we manage patients when they are taking antiretroviral drugs? So you need to prepare patients predictable and unpredictable side effects that may occur. So counsel the patients on the drugs that they'll be taking and some of the predictable side effects that they may experience, and also attend to those unpredictable side effects that the patient may complain of. Some of the side effects are mild and often seem self-limiting, while others are severe and life-threatening. You must continue giving a supportive, symptomatic treatment if a need arose. You can inform the physician immediately you notice any side effect so that he may either discontinue treatment or change it. Okay, but this is rarely required. So if serious and or maybe the life-threatening, you can always inform the physician and see the course of treatment that the patient may be put on. So the following are some of the side effects according to the classes of antiretroviral drugs. So suspected adverse effect due to NRTIs, but if the patient is on a nucleoside reverse transcriptase inhibitor. So we have peripheral neuropathy. Okay, so this is just general for the group. Pancreatitis, lipoatrophy, hepatitis, lactic acidosis, mitochondrial toxicity. Then suspected adverse effects that may be due to NRTIs, if a patient is on NRTIs. Here we have rash, fever, nausea, diarrhea, and the hepatotoxicity. Okay, when suspect adverse effect due to NRTIs, if the patient has, you can suspect the adverse effect due to NRTI if the patient has lipodystrophy or has GIT intolerance or has hyperglycemia or may have lipid abnormalities. Okay, what are the common overlapping adverse effects? So for all of them, the common overlapping effect may include bone marrow depression, and this may be due to azidovidine, okay, AZD, may be due to guaiaciclovir, which is just one of those groups of antiviral drugs, okay, and then cotrimoxazole, which is septrin. It's a drug that is taken to reduce infection before someone necessarily starts taking drugs, or as they are taking drugs, you suppress other infection. Then other common overlapping adverse effects include nephrotoxicity. This may be due to Antinfective, which may cause renal stones, and also if the patient is taking aminoglycosides or group of drugs known as aminoglycosides, these predispose to renal stones. Okay. Then peripheral neuropathy. Okay, this may be due to didanosine, may be due to stavudine, it may be due to cotrimoxazole or isoniazid. So peripheral neuropathy encourage patients to take a lot of water. Then other common overlapping adverse effects include diarrhea, which may be due to didanosine, okay, nefineva, and letoneva. So diarrhea can be seen. Okay, other overlapping side effects is rash that may be due to Bacava, efavirenz, nevirapine, dapsone, or cotrimoxazole. Some of those drugs, if the patient is on them, they may experience a rash. So cotrimoxazole is not an antiviral but an antibiotic. Dapsone, anti-tuberculoid drugs against leprosy. Okay, so those are some of the things. Then other overlapping side effects include hepatotoxicity, which may be due to efavirenz, nevirapine, NRTIs. Then it can also be due to rifampicin, isoniazid, fluconazole, or itraconazole, or ketoconazole. So these may cause hepatotoxicity. Pancreatitis, this may be due to didanosine, D40, okay, in children, or ritonavir. Then ocular effects, these may be due to didanosine, rifabutin, and ethambutol. Okay, so now let us now look at principles in management of adverse drug reaction. So if you observe the above stated adverse effects, you can determine the severity, establish the cause, that is it ARVs, consider duration or other drug, okay, and including self-medication. So you may need to ask patients some questions concerning that. Then consider other diseases like hepatitis, viral, immune constitution problems, so that you rule out other diseases. Okay, so now the fourth group of drug that we have discussed, antiviral drug, okay, and some of the principles in management of these side effects by ruling out other diseases, also by putting in the necessary remedies and ruling out self-medication. So the fourth group of drug that we'll be looking at, or that we are going to look at now, is antifungals. Anti against what? Fungal infection. So antifungal drugs are used to treat infections that are caused by fungus and to prevent the development of fungal infection in patients with a weakened immune system. A fungus is a living organism that can cause infection when it grows in the human body. In healthy people, fungal infections tend to be mild and treatable. For cancer patients, however, fungal infections may become severe and must be treated quickly. Okay, so the treatment of fungal infection depends on the type and the location of the infection. Superficial infection that may affect the skin, hair, and nails can be treated with topical, that is cream or ointment, or oral and fungal drugs. Systemic infections that affect the internal organs require aggressive treatment with either oral or intravenous drugs. There are three classes of drugs typically used to treat fungal infections. Okay, so we have the paulins, azoles, and the echinocardins. So those are the three classes of drugs or antifungal drugs that can be used. So when you talk of paulins, um, they are drugs that work by attaching to the sterol component found in the fungal membrane, causing the cells to become porous and die. The two paulins are most commonly used are nystatin, okay? The other name is mycostatin, and amphotericin B, okay? Amphotericin B or fungizone. So this fungizone or fungizone amphotericin B is part of the group of antifungal drugs known as paulins. Okay, so remember for antifungals we have paulins, azoles, and echinocardins. Okay, so nystatin is often used as a topical agent to treat superficial infections, or is taken orally to treat candida infections such as oral or esophageal candidiasis. These drugs are called lipid. These drugs called lipid formulation cause. Okay, so now here we are also now looking at the other group of drugs known as steroids. So these are lipid formulation. These drugs called lipid formulations cause fewer side effects than traditional amphotericin B, but are more expensive. That is the steroids. Presentation, you can have oral suspension and the like. So oral candidiasis, adults by mouth intestinal candidiasis, you can give those units. Indications for nystatin, that is vaginal candidiasis, okay? So they have what we call vaginal pessaries, 100,000 units that can be given. Side effects include nausea, vomiting, diarrhea, okay, with the high doses. Okay, and contraindication is sensitization. All right, so now the other group is the azoles. The azoles stop fungal growth by preventing fungi from making an essential part of their cell wall. So three typical azoles are ketoconazole, nizolol, fluconazole, and the triconazole. So these they prevent the fungi from making an essential part of their cell wall. So they prevent a cell wall growth in a fungi. Ketoconazole is the oldest of these three drugs and has been used since 1970s. It is slightly more toxic than the other azoles and does not work for aspergillosis and many candidiasis infections. Although fluconazole is effective against both superficial and systemic candidiasis, some strains of this fungus have now become resistant to the drug. So find that you are supposed to be fluconazole, you might have to use other drugs. Then itraconazole, this is the newest of the azoles and is effective against a range of different fungal infections. Unlike ketoconazole or fluconazole, itraconazole can be used to treat aspergillosis. Okay, then we have the echinocardins. Echinocardins are a new class of antifungal drugs that work by disrupting the cell wall, the cell wall that is the wall that surrounds the fungal cells. Okay, so the wall that surrounds that is the caspofungin, Cancidus is the first of this new class of drugs to be approved. Okay, so the first of this drug, one example is caspofungin. Okay, so it is an effective treatment for severe systemic fungal infection and is given to patients who do not respond to other therapies. That is the caspofungin or Cancidus. Side effects and fungal drugs that are applied topically rarely cause side effects unless the patient is allergic to the drug. Side effects are more common when drugs are taken orally or intravenously. The most common reaction from azole drugs is nausea, diarrhea, and other gastrointestinal symptoms. These are symptoms usually affect less than 10% of patients. For caspofungin also produces few side effects and the most common effect is a rash. Okay, then we have glycoflavin, which for indication here it's a ringworms infection of the skin, nails, or hair. Then the dose 500 milligrams, okay, or 1 gram as a single dose. So it is available in this, and then duration of therapy for hair and skin at least 2 weeks. For toe or nails 6 to 12 months you can give. Okay, then side effects: headache, skin rashes, nausea, vomiting, and photosensitivity. Contraindication: aggressively may be contraindicated in liver failure, okay, in nepophilia and in pregnancy. Okay, so now we have looked at antifungal drugs. Now the fifth group of drugs that we can look at is in antiprotozoal drugs. Protozoan infections are parasitic diseases formerly classified in the kingdom of protozoa. So they include organisms like Entamoeba, Histolytica, Plasmodium, some of which cause malaria, and Giardia lamblia. Okay, we have Trypanosoma brucei, transmitted by the sassafly and they cause African sleeping sickness. And we have the amoeba, that is Amoebozoa excavata. So we have those protozoa, eukaryotes, and unicellular organisms. And they have metabolic processes similar to those of human host than prokaryotic bacterial pathogens. They are single-celled beings which also cause diseases in humans, okay, which can be mild to life-threatening. Okay, the most common diseases caused by protozoa are malaria, amoebiasis, sleeping sickness, toxoplasmosis, and trichomoniasis. And protozoal drugs are medicines or drugs that are used to treat infections or diseases that are caused by protozoa. These drugs destroy protozoa or prevent their growth and ability to reproduce. They are available in liquid, tablet, and injectable forms. These drugs are to be taken only with a doctor's prescription. The common use antiprotozoal drugs are metronidazole or Flagyl. Okay, then we have frulazoridone. Okay, and then we also have chloroquine. Okay, so those are some of, and then we have hydroxychloroquine. Okay, so these are some of examples of antiprotozoal drugs. So metronidazole is active against a wide range of pathogenic microorganisms, notably species of Bacteroideae, Clostridia, anaerobic cocci, and Gardnerella. Vaginalis, trichomonas, okay, entamoeba. So it's very active against that. That is for metronidazole as an antiprotozoal drug. The mode of action of metronidazole, it penetrates the protozoan cell where the intro group is reduced to a hydroxyl or amine group, which reacts with the DNA and stops nucleic acid synthesis. Okay, the indication treatment of all forms of amoebiasis, trichomonas, vaginalis, barantitis, okay, leishmaniasis, and giardiasis. It is also used for post-operative infection. Okay, so in treatment of malaria, it is acknowledged malaria is acknowledged to be by far the most important tropical protozoal parasitic disease causing great suffering and loss. So here we have chloroquine that is used as an anti-protozoal. So more than 2 billion people, or nearly 40% of the world's population, they are at risk of malaria. So you find that here we use chloroquine as an anti-protozoal. The major load of morbidity and mortality due to malaria is borne by young children before they have developed certain degree of immunity to the disease. The treatment of malaria has to keep a pace with the evolution of resistance acquired by malarial parasites. However, its treatment is by antimalarial drugs, okay? So that is artemisinin and its derivatives. Mode of action of artemether, it clears peripheral parasite, falciparum parasitemia, more rapidly than quinine in children with severe malaria. And artemether injection can also be given. The drug is a strong citizenticide. Parasitemia clearance occur rapidly after administration. So the indication used for treatment of malaria due to falciparum, due to protozoal falciparum, and it's given mostly for those emergency management or severe management of malaria. So you find that you may need to use artemether injection in managing severe malaria. Okay, so the children doses there, those can be given. Okay, then the coartem, we have the children dose given per kg body weight. So 15 kg, 25 kg, 35 kg. So we have that graduation and the number of tablets that you have to give. Okay, then we have sulfadoxine, okay, plus pyrimethamine, okay, or fancida, which is that the non-combination of this, okay, for intermittent presumptive therapy or prophylaxis. This combination of antimetabolites of folate pathway has been successful operational anti-malaria drug in adults with highly developed resistance to chloroquine. Besides this, the commonest use of this drug is for standby self-treatment. Okay, so the mode of action, the drug acts by reciprocal potentiation of its two components achieved by sequential blockage of two enzymes involved in the bulk synthesis of folic acid within the parasites. Reports indicate that it clears parasitemia as quickly as chloroquine does. So Fancida or sulfadoxine pyrimethamine tablets are indicated for treatment of falciparum. Malaria prophylaxis with sulfadoxine pyrimethamine is indicated for travelers to areas where the malaria is endemic. Okay, then we have quinine, okay, which is a cinchona alkaloid. Cinchona is a tree from which this quinine was derived. So, which is a cinchona alkaloid, it is a rapidly acting blood citizental. So here, when you're looking citizencidal drug, so when you look at the levels, let's say the cycle of malaria, there's a part within the liver, okay, which is known as the citizental stage. So this one, it kills the citizentocytes. It is also, that's why we're saying it is citizencidal. So it is also effective against gametocytes. So it's gametocidal. So of Plasmodium vivax, Plasmodium malaria, and Plasmodium ovarium. It acts by producing changes in parasite membranes and in hemazoin of blood vacuoles. So treatment with quinine. Quinine is used to treat patients with severe and complicated falciparum malaria. Quinine is available for oral as well as intravenous administration. Okay, intravenous administration, it should never be given subcutaneously as this may lead to skin necrosis. When intravenous route is required, quinine should always be given by rate-controlled infusion, never by bolus intravenous injection. So we give it in a fluid. It can rapidly reduce sugar levels. So hypoglycemia due to hyperinsulinemia. Okay, hypoglycemia due to hyperinsulinemia is the most frequent adverse effect, followed by cardiovascular and neurologic toxicity. Indication of quinine, severe and complicated malaria, or it can be given in chloroquine-resistant malaria. Mode of action, it is a rapid-acting blood citizenticide drug and active against the gametocytes parasite. Okay, so parasite that is Plasmodium malaria and Plasmodium vivax, but not against the mature gametocytes of Plasmodium falciparum. Okay, and falciparum is the most common in countries like Zambia. So the doses there are variable, like 600 milligrams 8 hourly can be given for a maximum of at least 7 days and the likes. So if the patient is seriously ill, quinine should be given by intravenous infusion. Okay, that is 20 milligrams per kg body weight when you're giving an infusion. And then a maintenance dose of 10 milligrams per kg body weight can be given. Okay, so those for infants, you can calculate them using that guide which has been given. Okay, then treatment is for about 10 days, and then quinine injection infusion can be given 10 milligrams per kg body weight over 2 hours or 8 hourly for about 7 days. The side effects really for quinine can be shock, deafness, tinnitus, headache, nausea, poor vision, Okay, it may cause abortion. So especially if given in first trimester, so you find that um, any trimester of drug, you find that they might use coartem. Okay, it may cause hypoglycemia, vertigo, and GIT disturbance. A caution about this drug is that preferably given intravenously, we can dilute one in 10 or saline water for injection and administer over 2 hours. Contraindication if someone has hemolysis, tinnitus, or optic neuritis. Okay, so that is that one. Okay, so then the sixth is a group of drugs that we can talk about. Necessarily, these have to do with antiseptics or disinfectants or germicides. These drugs are primarily intended for the prevention of infection by destroying bacteria or preventing their growth. The differences among them are based primarily on degree of activity and how they are used. Antiseptics suppress the growth of microorganisms and are used topically, okay, to kill the infection. Okay, they are used topically, that is on the skin or mucous membrane. All of these agents are for external use only unless otherwise indicated. So we have the phenol, that is carbolic acid, historically one of the first antiseptic agents that is used. Phenol is the standard by which all other antiseptic, disinfectant, and germicidal agents are measured in their effectiveness because of its highly caustic nature, and it must be handled with care. Okay, the effect of phenol is coincident with the concentration. High concentration are germicidal and can cause tissue destruction. Lower concentration becomes antiseptic. Phenol is inactivated by alcohol because more effective and less damaging agents have been developed. Phenol is no longer used extensively. Never use phenol to disinfect rubber or clothes or plastic. So, in summary, we have been looking at different drug classification, and we have looked at 6 drug classification. Okay, so when we started, the analgesics, then we looked at the antibiotics, then we came to look at antiviral agents, then we looked at antifungals, then antiprotozoal, then we looked at the topical antiseptics. So antiseptics are not antibiotics. These are used topically for infection that is on the skin. Okay. So these are the 6 groups of drugs that we are looking at. Okay, so now with this covered, we will now look in more detail how analgesics work and the groups of analgesics that are there. We'll look in detail how antibiotics work and the groups of antibiotics that are there. We'll look at the antiviral drugs, the groups and how they work. We'll also look at antifungal drugs, the groups and how they work, how they block the multiplication at which stage and the likes. Okay, so that will be in the board series and other PowerPoint presentations that we are going to do, where we are just going to look at uh, isolated classes. Analgesics, we cover them extensively. Antibiotics, we cover them also extensively. So these are the groups of drugs. What you need to know when you say AN analgesia, AN absence, algesia, sensation. So the absence of sensation, pain there. This is what we call analgesia. Anti against bio, that is the life. So against the microbial life or bio life. Anti against the viral agent, so that is virus. And fungal working against fungal. So we have antiprotozoa working against the protozoa. So we appreciate when we talk about each and every class of drug, let's say group of drugs here, and see how the in pharmacology, how the drugs try to block the multiplication, okay, of these drugs, how they kill when you look at it and all of these drugs. Okay, so thank you very much for listening to Unit 4. Okay, so meaning Pharmacology 1 in the PowerPoint series has been fully covered. Okay, you can always look at each and every topic we have covered in Pharmacology 1.